So,
Good good evening, everyone. I welcome you all to this smart learning program on behalf of USI and ISU. Uh, we have selected a very interesting topic, which is of very practical value to all the postgraduates and also the practicing urologists. Dr. Amish Mehta is the convener for this session. The session is about urinary diversions after cystectomy, how I do it. So it's going to be a practical session where we have the expert faculty. We have Dr. Ganesh sir, Dr. Gagan Gautam, Dr. Hemang Bakshi, and Dr. Amar Singh. We have an international faculty. I welcome all the international faculty who are all the experts in this field who are going to enlighten us about the practical points, which will be, I'm sure, they will be of very great value to all of us in managing our patients. This is a subject which not only for uro-oncologists, even for pediatric urologists, for that matter, even for neuro-urologists, because all of us deal with the bowel and we should know how to use the bowel, how to avoid complications, and how to make our lives of our patients better. So with this brief introduction, now I request Keshav Murthy sir, the President USI, to give a brief address before I hand over to Dr. Amish Mehta. Keshav sir.
thank you, Dr. Suri, and it's my pleasure to welcome all of you to this smart learning program on urinary diversions. I must thank all the faculty who have joined in today to share their experiences about urinary diversion. This is a topic which all the urologists must be proficient with. Whether it is continent or incontinent diversions, the urologist must be proficient with this urinary diversion because it's going to affect the long-term quality of life of these patients. So it's very important to know about this, and I'm sure all the faculty who are there today with us will share their experience, and they are very experienced surgeons who have done urinary diversions for a very long time now, and I'm sure all of you will benefit from this smart learning program. I thank once again Dr. Amar Singh from US who has joined in to share his experience, and of course Dr. Ganesh, Hemang Bakshi, and Dr. Gagan Gautam. And thanks Amish for coordinating all this activity. Over to you, Dr. Surya Prakash.
Thank you, sir. Is Dr. Uttam sir there? He said he'll be joining. He's not there, no? He's not joined. Uttam sir? Oh. Okay, then we'll start. Dr. Amish,
Yes, sir.
start the session.
Sure, sir. Thank you so much, sir. So thank you very much, USI Office Bearers, Dr. Keshav Murthy sir, Dr. Mehta sir, ISU Chairman, Dr. Surya Prakash sir, for giving me this opportunity. The very purpose of this smart learning program, as we know now, is to make sure that the younger generation and residents take home significant learning material with them while being in the comfort of their own wards or home. The very purpose of bringing in all you stalwarts and experts from the field is the same. Though there are multiple learning opportunities available, when one particular topic is being discussed in depth by the experts, it is very easy for the learners to compare, to get the details through, to understand the complications, to understand the challenges and variations in the treatment. Keeping the same in mind, as it was suggested by the seniors, we have considered this particular topic for today's discussion, that is urinary diversions following cystectomy. Now we know for long that there has been quite a significant number of younger patients who do require these diversions. With increasing number of malignancy cases and options and opportunities of long-term survival and disease-free progress through their routine life, continent diversions as well as rest of the options are equally important for all the patients. For the same reason, it is now becoming equally important to get proficiency in this matter. Earlier, it used to be a case that considering that possible or perceived complexity of the matter of urinary diversions, many people would not just get into these details and they would just refrain from performing major surgery. But nowadays, considering the increasing need of this particular situation, I think it is the time that we have to get a clear and detailed idea of all the kind of various options. With due consideration, we have considered the different options. One is that the benign diseases. Dr. Ganeshwar is going to throw light on this particular complex disease with his experience, while rest of the talks are going to be about post-cystectomy diversion options. Without much ado, I would like to consider introducing our first speaker and to start first talk. However, our first speaker does not really require an introduction. Dr. Ganesh Gopal Krishnan sir is teacher of teachers with very renowned skills and expertise in the field, is going to discuss about options of continent diversions following extrophy of bladder. Though the topic is extrophy, basically it is about diversions which are applicable in patients as and when required. Over to you, Ganesh sir.
Thank you very much and good evening to everybody. Thank you to USI and to the ISU for asking me to speak, and specifically to Dr. Amish for having me on the session today. I would like to reiterate that this is an important topic, and I think it is well worth spending a couple of minutes on discussing some of the issues related to diversions, urinary diversions in particular. I presume you can see my slide and you can hear me too. Is that correct? Can you hear me and see my slide?
Full
Yes.
screen, sir. Full
Right.
screen.
Kindly.
Okay. You want full screen or this is okay?
And make it full screen, sir, if you nice.
You may start slideshow, sir. Yeah. Yes, sir.
Slide.
Well,
Fine, sir.
I'm going to
Thank you.
speak about continent diversion and bladder extrophy. And I'm not going to show any videos because I think I'm going to discuss mainly the philosophy related to urinary diversions in patients who need this operation, because some of the other speakers are going to cover quite a bit of these surgical aspects about it. I'm going to talk about the philosophy and the need for when you want to consider a particular type of diversion, with a focus basically on bladder extrophy, which is a benign condition. And as Dr. Amish said, we are looking at benign and malignant conditions too. So, as far as bladder extrophy is concerned, we know it's one of the most devastating congenital deformities that can afflict a young person. And I believe that over the years that I've been seeing these patients, the male sex suffers more from this disease rather than the female sex, because in the males, we know that apart from the bladder, it is actually the external genitalia which is actually also deformed. It's easier to correct the female external genitalia defects rather than the male, because the body image is shown clearly on the penis rather than anything else. And it can be exceedingly difficult, requiring multiple procedures on these patients. So I'm not going to discuss that issue, but I'm going to discuss about how we are going to deal with the bladder situation in these patients. Now, to begin with, I think augmentation is a given and is usually done early in childhood in these patients. While the bladder is closed, primarily at the age of 2 days or 3 days, whenever the child is there, we know that in our country that many of these things are left, and sometimes we see closures done in adolescents and sometimes we see closures done in adults. All of us have had experience where an adult comes with us with an absolutely open book ectopia, classical ectopia vesicae, and also in adolescents. We also know that most of them would have already had closures done of their bladders in childhood, but then they have been told that this will all settle down, the incontinence will settle down as this child grows up. So they wait and wait patiently before actually taking help from other urologists and doctors. One needs to be aware of the long-term consequences of bowel substitution when we are dealing with these patients, simply because of the fact that they are young. It's a non-malignant condition, and therefore have many years to live with bowel incorporated in the urinary tract. God never wanted intestine and urine to mix together, but He didn't give us alternatives which would actually be like urothelium, and therefore we have to contend with what we have at the moment, and we need to be aware totally of the long-term consequences, and therefore do not be in a hurry, but think very carefully before you use any form of bowel in the urinary tract for whatever reason. I think the most important parameter that we consider between a continent and an incontinent diversion in any benign condition or malignant condition is the eGFR. This is the single most important parameter that will decide. If the GFR is low, less than 30 ml, some people say 40 ml, then I think putting bowel in the urinary tract is doomed to disaster, and very rapidly these patients can succumb into renal failure, advancing renal failure. More so if they've had some past history of pyelonephritis, then this hastens the process of renal dysfunction even further. Of course, we have to have other factors when we incorporate bowel in the urinary tract, and this is for everybody, not necessarily for ectopia. Hepatic dysfunction, inflammatory bowel disease, lack of manual dexterity. I mean, if the patient cannot do self-catheterization or catheterize the mitrophan knob, you're going to have trouble. And you need appropriate counseling. The reason why I'm mentioning this is because I have patients personally who have come when they are 20, 22, telling me as to why they did this why I did the operation on them when they were 5 years old. They did not like the operation of mitrophan, did not like what was done for them. And I had to actually suffer the insults of many of these patients because of the fact that they were not consulted. So I used to tell them that, you were too young and you were not in a state of mind to make these decisions. And you have to now learn to live with this and accept it. But, it's easier said than done in many patients. So when we plan a continent diversion, we need to ask the following question, especially with reference to bladder extrophy. Is the patient actually continent? And you're doing a diversion, some form of continent diversion, because the bladder is too small or things are not appropriate. The second question we need to ask is the patient actually incontinent after closure of the bladder from extrophy, which is the usual situation. They have the bladder closure done, and then they continue to be incontinent as they grow older. And I think we need to look at the state of the existing bladder that is there before we decide on what to be done. We know that there are patients who come with the complete ectopia, and these bladders are absolutely very bad in terms of their fibrosis, etc., their capacity and their ability to fold into a spherical structure. So these are the three most important things that we need to consider before we embark on any form of diversion on these patients. So let's look at the incontinent patient whose bladder is not closed. All right, that we're going to take that first. And this is a condition, as I said, that is seen in both young adults and older adults. The question that we need to ask is this bladder salvageable? Is this a good bladder that can be addressed and retained? Supposing the answer is yes, this bladder, how do you decide? Well, you try to fold it. Under anesthesia, you try to see it. You look at the surface. Is it all irregular? Is there a lot of edema there? Is this bladder actually shrunk? Is there a suggestion that this is fibrotic? It's not going to mold into something. You're not going to dissect it away. So if the bladder is salvageable, then you have the alternative of closing this bladder, but the bladder is too small. You therefore have to augment it at the same time. Now, when you augment these bladders, you have to decide as to whether this patient is going to be continent through the urethra, or is it going to be incontinent through the urethra. If the patient is going to be continent through the urethra or incontinent through the urethra, you have to then do a Young-Di's bladder neck reconstruction at the same time because of the incontinence and the bladder is salvageable. So you must remember that these patients, because they've not had anything done to them, that their penis is also epispadiac. So that may have to be corrected in the same sitting if you have the will to do it. These are long operations, and sometimes we do it in stages in some patients. So if you have a bladder that is salvageable, you close the bladder, you augment it at the same time and decide whether you want to do a mitrophan to empty this bladder, or whether you do a Young-Di's bladder neck reconstruction and then decide whether this patient is willing to do CIC. I think these things have to be cleared very, very much before you actually put knife to skin on these patients. And it's not just one sitting that you make the decision. You have to call them back again. You've got to call the parents. You've got to counsel them and then let them make the decision as to what they want in their lives. Because if they are older people, they can make a decision. And many patients have said, I have known patients who have said, I'd rather live like this with a pad on my incontinence and manage with diapers. I don't want to have anything. Just leave me alone. So there are patients who have different viewpoints on this. If you have to do a complete reconstruction of some of these epispadiac deformities or ectopia deformities, then you have to throw in the abdominoplasty also. There are various ways by which the abdominal defect consequent to the pubic diastasis has to be corrected. You could use rectus slings, you could use rectus fascia. There are many ways by which these things can be corrected, and these are well described in most of the operative surgery books. Now, supposing the bladder is not salvageable, it's gone, it's completely useless. There's too much of infection in it. It looks very small. It looks very angry. And these sort of bladders, you may be forced to, in some patients, to actually take a biopsy to decide whether there's a lot of fibrosis at all in it at all. So if there is a bladder that cannot be salvaged, then you have to excise it. You can't retain it there and use it because it's not going to work. And then if you excise the bladder, in the males, you can't take off the prostate. You just have to take the bladder out because you need the prostate. They've got that part of the human anatomy works still for them. They've got normal testes. They can actually produce sperm. They can actually ejaculate because there's nothing wrong with that system. So you have to close the prostatic urethra, and you have to close it very carefully. Make it like a pouch so that whenever semen comes, it doesn't go back into the abdominal cavity because there's a defect. Now, this is a tricky procedure to do, and you need to cover it up. You need to cover the closure of the prostatic urethra with extra tissue that is available in the pelvis. And this only applies to men and not to anybody else. And you need to decide whether you want to do a continent diversion using bowel, or you use the ureterosigmoidostomy. This is a continent diversion using bowel. If you use the continent diversion using bowel, you'll have to have a Mitrofanov. Another way of doing a continent diversion is a ureterosigmoidostomy. Now, this is an operation which has been done for many years. For some particular reason, it seems to have fallen out of favor. And I still believe that this is a good operation in the index in a well selected patient. Therefore, you've got to be sure that the choice is good for ureterosig. You have to make sure that the rectum is continent. You've got to put the fluid into the rectum, about 200 to 300 cc. Let the patient walk about, see if they can hold this, and that will be the test of the rectal sphincter. This needs to be done before you decide on ureterosig. The most important parameter that you decide before doing ureterosigmoidostomy is how are the kidneys. Has there been evidence of pyelonephritis? Is there scarring? Because the moment you have bad kidneys, even though the GFR is commensurate with the diversion, if you do have evidence that there is renal dysfunction or some form of scarring, then I would say please do not embark on ureterosigmoidostomy. These are young people. They do get recurrent pyelonephritis, and then the kidney suffers. You have to undivert these patients. So be extremely careful when you do this. Now, when you do the ureterosigmoidostomy, you have to decide on the type. The MINDS 2 procedure is probably the best in this because it actually makes it a low pressure reservoir. And then if you have the ability, you can actually intercept the colon, the sigmoid, into this so that you have actually two streams, the stool as well as the urine coming out. This is also well described by the MINDS the German people who first described this MINDS 2 pouch. The interesting thing about this operation is that when it is done well, and if you follow up these patients, they will clearly tell you that they can distinguish between gas, they can distinguish between stool, and they can distinguish between urine very clearly. And they say that when I pass wind, I don't leak urine. So this is an amazing phenomenon that is there, and the patients are able to perceive it simply because the rectum sensation is still present in these patients. Now, if you're doing a continent diversion, not a ureterosigmoidostomy, but a continent diversion, then the Indiana pouch is probably something that I would prefer. You use I think Dr. Amar Singh is going to describe that, so I will leave that to him. But this is a good operation when you think that the ureterosig is not the best procedure. So you've got the bladder, which is not salvageable, and then you go ahead and decide on the type of procedure that you want to do. If you have an incontinent patient where the bladder has been closed, but the patient is incontinent, what are your options? Your options are a young D's bladder neck reconstruction. Sometimes this might have already been done by the previous surgeon, but it is ineffective. You may have to redo it again. And if you have a female patient, then you probably will have to put a sling at the same time. Either you can use a Birch-Colpo suspension or a regular sling so that you tighten the outlet a little bit more. Unfortunately, in the male, this is not an easy thing to do, and you have to rely on the trigone that is available, and then the real reconstruction of the bladder neck as described by young D's. In many of these patients, you probably will have to reimplant the ureters, and if you're going to do a augment with them, then of course the ureters are better reimplanted into the bowel segment so that you have a large amount of bladder and trigone to actually do an effective bladder neck reconstruction. And when you do this, when you do an augmentation on these patients, you have to decide whether they're going to do CIC through the urethra. Will they be able to do it? Is that urethra not sort of wavy around? Is it a straight urethra? Because many of these patients, after reconstructing their penis, have difficulty in doing CIC. So you must actually be sure that the urethra is of a good, not only patency, but also is a straight channel for them to do the CIC effectively. I therefore prefer to have two channels. I don't trust the patient to do CIC effectively. I therefore tell them I would like to have two channels. It's like a stepney in the car. You always have another wheel there in case you have a puncture. So they seem to agree to Mitrofanov in most of the situations. The other option is if you find that the patient is incontinent and he's had multiple operations and you can't assure him of total continence, close the bladder neck. There's nothing wrong, and therefore, right now, one of the operations which is favored by many people as in the adult population who have suffered for a long time with incontinence and a bladder close is close the bladder neck completely, augment the bladder with a Mitrofanov once and for all. And these patients are actually quite grateful that they're no longer on diapers. Again, be extremely careful when you close the bladder neck. You've got to take care of the prostatic urethra. What happens if the patient is actually continent? In bladder exstrophy, you have a small group of patients who are continent. And I'm very afraid of these group of patients simply because these patients, their bladder capacity is small. For some reason, they are incontinent. But I'm worried because I have seen these bladders being poorly compliant. So on the one hand, they have continence, but their bladder is poorly compliant. And this continence could actually be a red flag, and invariably deranged renal function takes place over time. These bladders are poorly compliant and they don't realize it. And if you have a situation like this, then you have to be either do an ileal conduit and excise his bladder completely, or do ileovesicostomy. You retain this bladder and just put a segment and bring it out. So you don't do any dissection in the pelvis at all. You retain everything there and do an ileovesicostomy, which is another good operation for in a situation like this where you don't want to meddle around in the pelvis, which has already been has been already dealt with in many procedures in these patients. We need to remember that in bladder exstrophy, it's not one fixed operation. Most of these patients would have 3 or 4 goes at their abdomen over the years. So finally, the take-home message in this brief presentation is any surgical exercise in this group patients in this group of patients is not a one-time thing. There could be reoperations as the patient grows. Very important that the patient goes from one place to other. The original operating surgeon may not have access to the patient at all. He just goes from one place to the other by word of mouth, saying go here or go there. I've been corrected. I feel that males are more difficult to handle. Females can lead an absolutely normal life. They can get married, and some of my patients have actually become pregnant. So I find that it's much more encouraging to deal with bladder exstrophy in the female rather than the male. So with that, I'll stop, and at the end, if there are any more questions now or later, I'll be happy to handle. So thank you very much, Amish, for asking me to be on this board. Thank you.
Thank you so very much, sir. That was an excellent insight into this complex situation. So there are two things that I would like to discuss. One is that we know that there are multiple avenues of management of this patient whenever the exstrophy is in play. The problem here is that patient's moral acceptance, as you very well said, that by the time patient grows, then only they realize that what has actually happened to them, and then they are not in control of that. One is that this moral thing, as well as the possible future complications, considering the longevity. What is the most likely, or what are the most likely issues and problems that they come across, so that our younger generation would know that they have to be prepared for this kind of complaints?
One of the most important things is this Mitrofanov. You see, you attach bowel, and initially you think that the bowel volume is about 250, but then over time it grows, And then what happens? These patients initially delay catheterization. And then when they delay catheterization, then the bladder becomes distended, and that Mitrofanov becomes difficult to catheterize because it gets kinked. And then what happens? They have a problem. They get an emergency. I've seen patients have ruptured bladders, and you've got to take them to the emergency and actually deal with this problem. So this is one of the major defects. So I have to tell them that overnight drainage. Every one of these patients has to have a catheter overnight drainage for two things. One, the bladder doesn't over-distend it because when you're sleeping. And secondly, it reduces the absorptive effect of the bowel and the urine together. So this is a major thing because these people are young, over time, they will get the absorptive effect. The second thing is because there is stasis in the diversion, this urine stain, stones. Stones are a major problem in some of these patients. Again, because of stasis, they are in a hurry. They don't empty their bladders completely. So there's always a bit of residue. And we know that whenever bowel is incorporated, there's always bacteria. So, the effect of bacteria, the effect of mucus, all this aids to the presence of stone formation. Certainly, we have to be aware of the fact that over time, renal failure dysfunction can occur. I've got patients who have had ureterosigmoidostomy done, who had continent diversions done, had a transplant too. So, this is something that, it's easy to put bowel and handle bowel, but I think the long-term consequence, if you follow your patients long enough, they have it. I've had patients who developed malignancy also and had to take the whole bladder out. Therefore, these are serious complications, and although they're not very frequent, it is just that, when you do for cystectomy for malignancy, the longevity of that individual is much less than somebody who do it for extrophy.
Yes, sir.
Extrophy is happening at a much younger age. So their lifespan is much longer than somebody who's had a bladder cancer. The bladder cancer fellow is already 55 plus 60. He's got other comorbidities. He's not going to live as long as a normal extrophy. So, we've got to take care of the benign conditions for which we have to do diversion. TB, for example. So we have to be very careful when we use bowel in the urinary tract. I hope I've answered your question, Amish.
Yes, sir. It is very well explained, sir. There's another issue would have been the falling experience in terms of managing this patient for urologists. For example, ureterosigmoidostomies. Now it's not being performed that frequently. So it is not just a question of surgical expertise, but also a question of actually managing these patients down the line, particularly for benign conditions. I'm sure that it's going to be a long way for all the urologists in the coming generations, that they will really have to get into this particular practice of how exactly to manage these patients. Not only that, to learn that how to manage surgical expertise of these surgeries. Let us hope.
You mentioned ureterosig. I mean, I also tell them that they need to put the catheter in the rectum overnight.
Right, sir.
Yeah. So, this overnight drainage of the bladder is a very important factor in whenever we deal with these patients. So it sounds a little harsh on them, but they do accept it. And we know that patients who had ureterosigmoidomy, if they don't follow some certain principles, they slowly get into hyperchloremic acidosis, they get into renal osteodystrophy, etc. So there is problem with that, especially in older people. So we need to be extremely careful.
Right, sir. Thank you so very much, sir, for an excellent
Thank you very much
on this matter. Dr. Surya Prakash, sir. Sir, is there any question from your side, sir?
Yeah, okay, Amish, we'll take in the end questions for the lack of time. We'll move to the next question. Thank you, sir. Ganesh, sir.
Thank you.
Thank you, sir. Our next talk would be delivered by Dr. Gagan Gautam, sir. Sir is chairman of Uro-Oncology and Robotic Surgery at Medanta Hospital, Gurugram. Sir is already with us. Kind request to sir to start screen sharing. Sir is going to talk on technical considerations of ileal conduit formation after cystectomy. This is one of the most common surgery being performed, and we would really like to have the details that sir may want to explain to us. Sir, over to you.
Thank you so much, Dr. Amish. It's really a pleasure and honor to be a part of such an eminent training program and something which I'm sure a lot of residents and practicing urologists would really benefit from. Thank you so much for this opportunity. So in all the talk and the interest that is there in continent diversions and neobladders, I think one thing is clear and apparent to all of us, that ileal conduit remains the most commonly done urinary diversion worldwide. And I don't know of an institution where neobladders or continent diversion are done more often or more commonly than an ileal conduit. The reason for that remains that this is probably the safest way to do urinary diversion. This is my disclosure about using AI for the preparation and drafting of slides for this particular presentation. However, all clinical techniques and surgical videos that are shown are original edited footage from our own cases. And I would like to also acknowledge Dr. Harshit and Dr. Supradeep, who are our current robotic uro-oncology fellows, for their help in getting the videos together for this presentation. So conduit is the number one and the most commonly used diversion, and that is because it is something which can be done in a very easy way, and I think every resident should or would know how to do a urinary diversion using ileal conduit. It is the diversion which has the least complication rates out of all the diversions, and it has the longest long-term data and track record available amongst all urinary diversions. Hence, this is if there is one diversion that all of us need to know, then it's the ileal conduit. The initial part is, of course, how to mark the stoma. Without marking the stoma, I don't think we can proceed safely in this situation. Here we have elevated the legs of the patient with the knees straight to define the lateral border of the rectus. And then we are marking transversely the area which is the most prominent in the skin mound that you can see in the sitting as well as the lying down position. And thereafter, once we have decided that area, we put the patient on the flange with the help of a belt, so that we make sure that the patient is not having the flange covering the umbilicus, and that the flange is not overlying the belt line or any skin folds. And this is and we ask the patient's feedback at the time of the marking of the stoma, whether the location also seems to be appropriate to him. Now, everybody wears the belt at a different level, so their own lifestyle would also determine where we are going to place the stoma initially. And marking the stoma is perhaps one of the most important things to be done. Apart from that, the diversion really begins when you start mobilizing the ureters, because the fate of the ureters depends on how well you have mobilized them and whether you are too close to the ureters or not. It's very important to leave a layer of fat around the adventitia of the ureter, because that's how the vascularity is ensured in the ureter. One should not really thin out the ureters too much. Here, this is the medial umbilical ligament on the left side being divided, and the pedicle is being mobilized. The left ureter obviously needs to be a little bit longer than the right side, but one also has to be very careful about the location of the disease. Sometimes if there is a disease near the insertion of the ureter or in the muscle invasive disease near the ureteric orifice, you should not go very close to the bladder and one should avoid the positive surgical margins under all circumstances in this situation. Once the ureters are mobilized and the bladder, of course, has been removed here and the lymph node dissection has also been done, we want to tunnel the left ureter under the sigmoid. And here we have to be very careful that you should not tunnel the ureter too low. Mobilize the ureter till just above the iliac vessels. That is usually good enough for the left ureter to come to the right side without any problem. But we want that the ureter should come out of the tunnel relatively high, almost at the level of the aortic bifurcation, or even higher a little bit. Because at that particular point, we would know that there would not be any sharp kink in the ureter. The other thing to make sure is to ensure that you are not going to have any kind of a rotation or torsion of the ureter, and one has to see that when you're bringing the ureter to the other side. Following that, we need to select and isolate the segment. Usually 15 to 20 centimeters from the iliocecal junction is the best way, but you can actually also eyeball it. And we came to know from our GI surgery colleagues that you can actually just take the ideal segment would be about 2 free-lying loops away from the iliocecal junction. So we don't actually measure it, but we just take 2 free-lying loops and we mark the distal end with the black thread and the proximal end, after measuring it with an umbilical tape at about 20 centimeters or so, with a white thread. And of course, the color coding can be individualized as per your preference. Now, we divide the distal mesentery using a white load of the Sureform robotic stapler. And we do have to mobilize the distal part a little bit more. We want to dissect out the distal part of the mesentery more because that end has to come out in the form of a stoma. The proximal part, we just need to fire one stapler across the bowel, taking whatever mesentery comes along with it. We don't need to go down very deep in when we divide the proximal mesentery. Now, ideally speaking, in open surgery, if you're doing it, it's very easy to trans-illuminate it and make sure that the arcades are clearly visible. But we have never done it in robotic surgery because maybe we don't divide the mesentery that much. And in any case, if you want to be very sure, you can actually do an ICG also if you want to, but we rarely do it. And we've never had a problem with an ischemic bowel in this situation. The next step in this situation is to restore bowel continuity, and again using the Sureform robotic stapler. The side-to-side anastomosis is done. The proximal and the distal bowel loops are taken. One of the tricks that we have learned along the way is that it is better to fix the Sureform stapler in one particular place and then slide the bowel over it instead of trying to manipulate the Sureform stapler too much. So here the Sureform stapler is fixed in a particular place initially. The bowel is slid over it and it is fired. And the entire bowel anastomosis can be done in maybe somewhere between 5 to 8 minutes. So then of course the ends are all closed off with again the blue fire of the staple. And sometimes, most of the times, you would require two. Even for the lumen, we use two fires of the stapler to make sure that there is no narrowing in the ilio-ileal anastomosis. Once that is complete, it is the time to do the uretro-ileal anastomosis. Now you can do a Bricker or a Wallace. I think the latest meta-analysis done in 2025 actually does not show any difference between any of the complications or even the stricture rates between the two types. So it's more of an institutional and individual preference. Here we have the left ureter, which is being spatulated. There was a stent from the previous TURBT, which has been removed and will be replaced. We use a continuous 4-0 Statafix uretro-ileal anastomosis using the Bricker technique over a 6 French DJ stent. While manipulating the ureter, one must try to avoid holding the ureter directly. There's a fat pad around it which can be held to manipulate it. We don't want to crush the edges. On the left side, one of the tricks that I have learned is that instead of using a 26 French stent, if you use a 28 centimeter or a 30 centimeter stent, long 6 French stent, then it is easier to come out, and sometimes it comes out on its own. Sometimes with a small, shorter stent like a 26 centimeter stent, you may be struggling a little bit and during flexible endoscopy to remove the stent. So this using a stent avoids the use of ureteric catheters and bags outside or the danger of it slipping out. DJ stents are very secure and can be removed subsequently via flexible scopy done under local anesthesia. Sometimes they also slip out on their own and can be just manually removed. Now, the last and the most important part, if I may say, is creation of the stoma, because that's what the patient is going to live with for the entire life. And we've already pre-marked the site from the preoperative assessment. And once we've made that incision there, we reach up till the anterior rectus sheath, and we make a cruciate incision on that and fix our 3-0 vicryls on that, which will later be fixed onto the serosa of the bowel. So 4 vicryl sutures have been taken here. And one has to be really careful on how you bring the conduit out. We usually use a small port and we hold it, with a needle driver, we hold a suture which has been passed on to the end of the stoma and we pull it out. It's very important to make sure that you've oriented the mesentery properly. It should be at a 2 o'clock position towards the left shoulder, that like everybody already knows. And then the first step after pulling out the conduit is to fix the serosa of the bowel to the sutures that have been taken in the anterior rectus sheath. And subsequently, we can open the stoma and then go ahead and do an eversion sutures to create a nice pout. I think one of the problems that can occur is that you can have a flush stoma, but if you got enough of the conduit out and you're taking proper stitches, at least 4 stitches from the 4 edges to evert the stoma, you can get a good pout, and then the flange fits easily, does not leak, and it's easy to manage. We leave a Foley catheter inside because obviously there are no ureteric stents or there are no ureteric feeding tubes, so we just go ahead and put a Foley without inflating the balloon, so that just to decompress the stoma for a few days, and then that is removed before the patient is discharged. Now, these are some of the pitfalls that can happen in patients who are undergoing an ileal conduit, and it is much easier to prevent them than to manage them subsequently. Ischemic conduit can be a potential disaster. I think one of the things that we have to be aware of is that if there is a bluish edge there that you're seeing at the time of maturation of the stoma, it's always better to trim it down to a bleeding bowel before you start spatulating, before you start making a stoma. The other important steps are that you have to ensure that the mesentery is divided under vision. We have to make sure that the proximal part of the mesenteric division is not very deep, because that's where ultimately the blood supply is coming from. And if these things are ensured, having an ischemic conduit is extremely rare. Sometimes the bowel edges, the proximal and the distal loops of the bowel, sometimes they get ischemic when just before you're doing an side-to-side anastomosis. And sometimes you have to discard a few centimeters of bowel, most commonly on the distal side, before you do the anastomosis. And because we are doing a side-to-side anastomosis, that's never a problem. You can just make an incision a little bit more distal, fire your staplers, and go ahead and divide remove the proximal part, the ischemic part of the bowel that is not nice and pink. Like I mentioned, you can also use indocyanine green under Firefly to actually make sure that the vascularity of the bowel and even the ureters, for that matter, is very well there at the time when you are completing the procedure. Tension on the ureters can lead to stricture and leakage. We want to avoid that under all circumstances. So we have to mobilize the ureters fully, but not too much, because the more you mobilize, the less the vascularity. The ideal sweet spot for the left side is just above the iliac vessels. And on the right side, of course, we can trim a large amount of ureter because we need relatively shorter ureter on the right side. The mobilization remains the same because you'll also mobilize the ureter till just above the iliac vessels there as well. To avoid kinking of the ureter, like I mentioned, we want to bring the ureter high behind the sigmoid and not too caudal, a little bit more cranial. The ureter should actually be coming almost at the level or even higher than the aortic bifurcation. And that helps us in being able to make sure that there is no acute kinking of any ureter. Flush stoma we have discussed, but a twisted conduit can easily be prevented by making sure that you are not having you're having the mesentery at the 2 o'clock position. And when we bring the stoma out, we actually put the camera inside from one of the ports to make sure that there is no rotation of the conduit and that the conduit is coming out straight without any twist outside the body. So if I was to summarize 4 things before I wrap up, I would say that the operation is won or lost actually before the incision. A very diligent planning of the stoma is essential. It can prevent a lot of complications and quality of life issues if we have given the proper attention to making the stoma site in the evening or the day before we are doing the procedure. We have to protect the blood supply of the ureters and the bowel at every step, because most of the complications in this can be prevented by technical diligence. The ureteric anastomosis should be, whether you do Wallace or whether you do Bricker, it doesn't matter. Both can give you excellent results if you are familiar with a particular technique. But the ureters should be wide, they should be watertight, and they should be tension free. Our initial instinct is to suture the ureters really tight against the bowel, because we feel that that's how the leakage is going to be prevented. But actually, that may actually cause more ischemia at the edges. So it should be snug. It should be firm, but you should not be super tight when you're taking the sutures between the ureter and the bowel. And the deeper bites in the bowel and thinner bites on the ureter, we don't want to kind of compromise the lumen of the ureter by taking these bites too much into the lumen of the ureter. And of course, we have to build a nice spout, and that is very easily done if you've got enough of the conduit out and if you have placed the sutures very nicely in most of the patients. With this, I want to express my gratitude once again to USI, ISU, Dr. Amish, and all the organizers of this meeting for giving me an opportunity to be a part of it. Thank you so much.
Thank you, sir. Thank you for an excellent talk on this very common topic and a matter of very common interest. One thing is, sir, what is your take on retroperitonealization of LEL conduit? Do you want to consider it in any such case? Second, along with that, sir, is that the site of your stoma formation is a bit higher than the level of umbilicus. Though it seems like that would help the shorter mesentery to come to allow the conduit to come to the abdominal wall. Then in that case, do you really consider that any shortfall in terms of length of conduit while both the ureters are coming from its proximal end?
So let me answer the first. I can answer the first question. I have never retroperitonealized the conduit, both in open surgery and also in robotic surgery. I'm not aware of any distinct and proven advantage of this particular technique, but what I do realize is that every surgical technique is based on an individual surgeon's preference and experience, and I have absolutely no objection to somebody who would want to do that. The second aspect about the stoma side, I think one of the things that maybe we had a preconception was that it has to be at a particular site outside. Actually, it depends on the patient. In the patient that we had shown in the video had a big pannus, and if we were to put it below the umbilicus, it would come in the skin fold of the abdomen. So that is why we had to move the stoma a little bit higher. But actually, the stoma can be at the level of the umbilicus, above the level of the umbilicus, or below the level of the umbilicus, depending upon how the body habitus is and what is the patient most comfortable with. Yes, we do realize that if we are going above the level of the umbilicus, the conduit does have to be a little bit longer. I feel that you have to bring it up a little bit from the pelvis, so it has to be a little bit longer. But apart from that, I don't think that there is a huge difference in the technique or in the outcomes as long as the patient has a stoma which aligns to his body's anatomy and physique.
Right, sir. Thank you so much, sir. Dr. Suryaprakash, sir, any questions, sir?
Dr. Gagan, great demonstration. Thanks for that. I have two questions. We are all concerned about the tunneling the left ureter. I've seen few surgeons in US. I think this is a technique demonstrated by Dr. Gill. He tunnels the proximal ileum to the left side and does the ureteric anastomosis. And they say that it's easier to tunnel the ileum rather than the ureter. What's your take on it? Second question is, any specific reason why you use Stratafix for ureteroileal anastomosis, or just your preference?
Okay. So to answer the first question, I think it has got more to do with what kind of a length of the ureter you have available. I think in most of the circumstances, we have good length of the ureter available, and that can be tunneled high and got to the other side. If you have a short length of the ureter available, then maybe it will be better to tunnel the ileum actually and take it to the other side, because then the ureter can be implanted a little bit more proximally rather than distally. What I would like to share with you is that when we started doing robotic cystectomies and urinary diversion in about 2011, 2012, initial first 2-3 years, I had a lot of issues, and a lot of people developed strictures in the ureteroileal anastomosis. And it was something that was quite distressing for me to see, a lot of strictures developing. But in the last 7-8 years, I have hardly seen even a single or maybe one stricture in the last 7-8 years. And later on, I realized was that in order to decrease the tension on the anastomosis, I was leaving too much ureter hanging around, before at the time when I was doing a Bricker. But later on, I realized that you have to really trim the ureter down a lot. Even the left ureter, you trim the ureter down, sometimes you have to remove the distal 3 or 4 or 5 centimeters of ureter. As long as the ureter is coming easily without tension, we don't want to leave any redundant ureter there, because redundancy in the ureter will decrease the ischemia. And obviously, we have over the time also learned that the mobilization of the ureter doesn't need to be done beyond a particular time point to ensure the vascularity. And thirdly, sometimes we have also used ICG to look at the terminal part of the ureter to see whether that is well vascularized or not. So these are the things which have prevented it. And as far as your question on the Statafix goes, well, I'm not really, I wouldn't say that this is the best suture or only use this. It is a matter of personal preference. One thing that I realized was that using V-lock was a bit too rough. Even the 4O thinnest V-lock that was available was a bit too rough for the edges of the ureter. I have used PDS, and that works pretty well. But I like the advantage of being able to use a suture which does not become loose once you have tightened it. So in that sense, Statafix was a good balance between a V-lock and a PDS, and we would be able to pull it, and without becoming loose, we would be able to confidently close the stitch line.
Thank you. Ganesh sir wants to.
Yeah, I just 2 points that I'd like to mention when we are marking the stoma is I always check with the patient whether he's right-handed or left-handed. I also check with him whether he's a golfer. I've had patients where they've had the stoma put on the right side and it comes in the way of the golf swing. So these are some issues. I mean, every patient is not a golfer, I think. But in today's world, many people can get this problem. And I always ask the patients about this. The other thing is, when I mark the stoma, I make the patient sit because you saw the picture that Gautam showed, the potbelly fellow. I want him to see. I said, can you see the stoma? Some of these guys are so big they can't actually see where the stoma is, you see. So I asked them, can you sit and see where the stoma is? Then I said, okay, that's where it is. So you may have to do a little bit of shifting. I'd like to ask Gagan, what tricks do you have for somebody with a thick mesentery, And have you ever done the Turnbull stoma in a situation where it becomes necessary?
No, sir, I don't have experience of that. Maybe you can share and let us know in this particular situation about the Turnbull stoma.
No, the thing is that you guys are doing so much of robotic stuff, so I'm wondering whether this becomes a difficult situation when you're handling with the robot, that the mesentery is not coming up, it's not making a nice rosebud, the fellow is thick and fat, and it gets a little frustrating. I admire you fellows doing this operation. But when push comes to a shove for these patients who are thick and heavy set.
I've had a little bit of issues sometimes with the neobladder, sir, with the mesentery, being thick and short and causing a problem. But to be honest, for the conduit, it's a more forgiving kind of a situation. So no, I haven't faced issues where the stoma is not coming out because of a thick mesentery. But having said that, maybe I'll have one tomorrow, and then I'll be calling you on your on an emergency line.
No, I think that the Turnbull stoma is a good sort of fallback defensive thing, because you then don't get a classical rosebud that you showed very nicely, but you have the whole conduit coming out, and you sort of open it on the antimesenteric border, so you get a slightly bigger stoma, and then later on, as time goes by, these things mature, and because the bag that you fit onto that is little bulky, you need a bigger bag than it is, especially with a thick, and this happens in thick set little fat fellows. So later on, as time goes by and matures, you can divide that and make it into a rosebud later on. For some reason, it seems to work, but not on the day of the operation. So I thought I'd just share this with you, so that you guys will do so much of these robotic stuff that it amazes me. So we are all still far away from that.
Thank you for the tips. I'm sure that if I run into trouble, then I will know what to do next in this aspect.
That's a nice demo. That's a very nice demo, Gagan. All the best. God bless.
Thank you, sir.
Thank you
so much. Thank you.
Amish, there's a question to Dr. Gagan in the chat box. Infant feeding tubes versus stents. Which is better? What is your recommendation?
So I feel both do the job very well. And traditionally, we've been taught to use infant feeding tubes. But again, as we were talking about robotic and how easy or difficult it is, I found it a little bit inconvenient initially, at least, to be able to tunnel the infant feeding tubes all the way from the outer end of the stoma through the back end and into the ureters. Though people do it all the time, and in fact most of the surgeons doing robotic cystectomies and conduits are actually doing this only. At that time, we explored the option of just putting in a DJ stent, because it takes literally less than 60 seconds to put in a DJ stent and putting in a catheter. And later on we found that there wasn't any risk of the feeding tube slipping out or managing too many tubes from the outside. Of course, it does have a flip side, because you have to then kind of in a lot of situations, in fact in most situations, you will have to get the patient in and do an endoscopy through the conduit and with a flexible scope and pull the stent out. But at least at the time of the procedure, it saves time and inconvenience. So my preference has always been to do put a DJ stent. In fact, I would say in the last 10-12 years of doing robotic cystectomy, in the initial 1 or 2 years we used feeding tubes, but for the last 10-12 years I've been using stents and pretty happy with that.
Thank you. I think Dr. Arvind, that answers your question. Dr. Amar Singh has a question, raised his hand.
So in US about 3-4 years ago, a paper came out that said stenting actually made the outcomes worse. So after about first 15 years of my career, I used to stent everybody, both with robotic and open. Now for the last about 4 years, we have gone 100% stent free. And the outcomes have actually been better in terms of ileus, UTIs, all of those things. So I'm curious if any one of you guys have gone to not putting any kind of stents in ileal conduits per se.
So that's very interesting. No, I'm not aware of anyone. I mean, I may be corrected, but I'm not aware of anybody that I've heard in our Indian urological community where we are not using any stents or any ureter catheters. But what is your experience, Dr. Amar Singh, about the strictures and leakages? They just remain the same all the time?
Almost none. We use, similar to you, I use a Stratafix to do the anastomosis. And about a couple of years ago, we did a bladder cancer panel at AUA and also at Robotic Urology Society here in the US. And I know all the guys at Sloan Kettering, Hopkins, Simone Cavalier in Chicago. Most of us, we don't use stents anymore, unless it's now exceptions are probably if it's post-radiated or something else, but routine conduit, both open and robotic. I've gone stentless almost for 5 years now and have not seen any change in urine leak, pylo, ileus, fluid collections, any other complications.
And have you noticed a benefit? Of course, it saves you an extra step and later on trouble in removing it if you put a DJ stent. But in terms of post-operative recovery, have you seen an improvement in the patients?
So I have to pull that paper. One thing I know for sure, I think I don't have our data collected, or I can't tell you based on mine, but anecdotally, they seem to be doing better with a little bit less issues with ileus.
Okay.
And so you can postulate, and all surgeons, we always like to pontificate and come up with ideas. My thing is, without a stent, I think the ureter is more pliable and bowel can move around and things like that. But the other part of it is there is definitely less incidence of pylo and things like that in the perioperative period.
Okay. And would you leave Foley and the stoma or not even
So
that?
yes, so that's the thing, because the ileum becomes, so the way at least we think about it is that after any kind of cystectomy, open robotic, regardless of the approach, the terminal ileum and bowel becomes paralytic in the perioperative period. And in order for that, so what I do is I actually put a Malacot catheter, 24-26 Malacot in the conduit, because this way it can drain better, and they just cut it and it just stays there. And once their GI function opens or they start having flatus, you pull that out, because then the intestinal segment is peristaltic and it can get the urine out.
I think
And
that
that's
makes a lot of
interesting that
sense.
you
A
asked that,
Malicot will
because
probably,
the
yeah.
first time I did, first one I left without a stent, I had all of a sudden patient is not making much urine, got renal failure, and then I scanned them to find out that the conduit had blown up like a balloon on post-op day 1. So then we just stuck a Malacot in and that resolved it. So since then, I talked to a lot of folks who do cystectomy out here, and most of us have gone stentless, but we do leave a drainage in the conduit, and you remove that the moment the GI function returns.
And I don't think there's much of a difference between a Foley and a Malicot for the purpose that we are talking about, I think.
The biggest thing is with Foley, I don't have to worry about blowing the balloon up. I mean, because we usually like to just cut the little bit of segment. So Malacot, the mushroom, keeps it inside without you having to, and then you can cut it right at the level and back and still go on there. So it's a little bit more functional. That's all.
Awesome. Thank you so much. That was
Thank you
very
so much,
interesting.
sir.
Thank
you so much again for an excellent discussion on this relatively untouched topic about stentless anastomosis. But I think that is going to be very useful consideration for everyone who is doing this particular surgery regularly. We shall proceed with our next talk, which is going to be delivered by Dr. Hemang Bakshi, sir. Sir is head of the Department of Uro-Oncology at SCG Asa Cancer Center, Ahmedabad, with a very long experience of teaching as well as conducting fellowship programs in uro-oncology field. Sir is going to enlighten us about neobladder creation and relevant tips and tricks. Over to you, Bakshi, sir.
Thank you, Amish. And I thank the USI and ISU for the opportunity. We had a very interesting discussion and great learning tips from Dr. Gagan. So to add, before I start to add a third dimension to the stenting issue, I use single J stents. So we have DJ stents, no stents, and a single J stents amongst all three of us. But over the last decade, I have used a single J stents. They're easy to procure, easy to slide in, and I mean, I'm happy with it, but it's a personal choice, of course. So, but I won't be talking about that. So I'll be focusing on the neobladder and the tips in open and robotics. So just a quick recap. We all know this, but just a quick recap for the students. For any neobladder, we usually isolate a segment of bowel, which is around 45 centimeters to 50 centimeters, depending on the technique. And classical Studer has this configuration. The ilioileal anastomosis, Studer used to do a hand-sewn one, then the neobladder segment was opened and the ends were closed and the ureters were implanted in a Bricker's fashion, right? So this is the classical teaching. Then the neobladder is opened up, the posterior limb is sutured, and then the anterior two limbs of the anterior wall. The bladder neck is created at the most dependent part, and then the vesicourethral anastomosis. So these are the classical steps, and I'll be showing a video on an open neobladder. So on the left end of the screen is the head end, down is the foot end. The cystectomy has been done. This is just a short 3-minute video. So this is the bowel ends have been dropped inside the two cut ends of the bowel, and this is the neobladder, unopened segment. So we mark a chimney which is about 7 to 8 centimeters long here, and take a space sutures. This is a monocoil stitch, and then the bowel is opened. On the mesenteric side, again the mesenteric border with diathermy. So we don't use any mechanical or chemical preparation of the bowel. We use a modified ERAS protocol and allow the patient to have liquids just up to 2 hours before anesthesia. We load them with carbohydrates. So then this is the open bladder. So this is the posterior segment being sutured. And we use a single layer suture. This is a straight needle 4O Vicryl from J&J, and that really speeds up the suturing, unlike a curved needle. Sorry, the screen is rotated now a little bit. So the head end is at the bottom of the screen, and the foot end is below. Now we're back to the head end on the left. So once the posterior plate is done, we take a stay suture from the unopened end of the chimney to the left-hand side of the day. So this makes two limbs of the neobladder, the anterior, the lower limb and the upper limb of the anterior wall. The chimney goes over to the right, as you can see. Sorry, the audio, I think. So this is the posterior limb in suture. This is again the forearm EDS. And then the upper limb. So just the seromuscular layer continuous. And you can see then the ureters are implanted into the chimney of the bladder.
You're right.
One on each side within the Bricker anastomosis. You can see the umbilicus here and the foot end is this side. And now the last part is the anastomosis of the neobladder, neourethra, and the native urethra. So we use continuous sutures. This is 3O monocryl. And we tie the ends at the ends. So 4 throws on each. And yeah, sorry. Right. So coming the difference between the robotic neobladder and the Studer neobladder, which we do in open. So we use the Karolinska technique for the robotic, where we isolate 50 centimeters of the bowel, 10 centimeters on this side, and then we do the anastomosis first, bring this point here, and do the anastomosis can be directly into the chimney using the Wallace technique or the Pricker's technique, which you can individually implant the ureters. And this would be the final configuration. So it's a modification of the Studer. The most important point is double cross-folding of the mesentery, which is very essential to the success of the neobladder. And we'll be showing the robotic technique. The radical cystectomy has already been done in a male patient. So I think we've seen these images. Right. Why the video is not playing? Just a moment. Sorry about this, but
It's not playing.
yeah, I'm just trying to get this.
Yeah, there is a separate video in your desktop. You can play it, not from the PPT.
Okay, yeah, I have it. So let me. Sorry about this, but let me just
Stop sharing
go
and you can
back.
share that.
Yep.
Now delete.
I think I'll stop sharing and
Yes, you can just share the video quickly.
yeah, just sorry about that. Let me check with
No
my.
problem. What percentage of your new bladders are robotic, sir?
So almost 90% would be robotics. The only indication where I would do an open bladder is financial. Majority of the new bladders would be. Can you see the screen now?
No, not yet.
Not yet, sir. You may please start sharing first, sir.
Yeah, okay. Let me check.
Open it, minimize the window, then share it.
Yeah, I've opened it. I have now minimized it.
Now, share, go to share.
But I'm not getting that video on the. Just getting to PowerPoint. Just a moment. I'll just minimize this. Open this.
Or maybe, sir, we may consider running it frame by frame with a cursor in case it is still not playing.
No, I'm not able to. Yeah. Just allow me one more moment. Otherwise, I'll do that exactly as you say. I'm sorry about this. Let me stop sharing right now. So I have the Neo bladder here, but I can't have this video is playing, but I don't know how to share it. So it's there on my desktop and it's playing.
You click the share on this Zoom. Once you minimize, you'll be able to see multiple windows. One of them will be the video.
Yeah. Yeah, got it. Now I think I'll be able to play it. Sorry about that. Yeah.
Yeah. And now we are seeing
Yes.
that. Oh, yes, yeah, now it's okay.
Okay, so can you see the full screen or it's just...
Yeah. Now video is playing. Very nice.
Right. Sorry about the delay. So we measure 20 centimeters of the bowel from the IC junction. Then we take a stay suture with silk, and we also take a poppet from the abdominal wall. So that's a stitch from the abdominal wall which holds up the mesentery, the segment of the bowel. Then we use ICG to trans-illuminate the mesentery. I use ICG in all cases. I know it's not needed. Most of them don't use it, but I still prefer to use it over all my neobladders. And then the distal end of the neobladder is closed. I use a 3O monocryl here. And then that was the first mesenteric cut, which is deep. So distal segment of the neobladder is isolated. Now the proximal segment closed, which will form the chimney. And again, I use a puppet. So 3 sutures are used to hold the bowel up. And this mesenteric cut is not as deep as the first one, because this will form the chimney. I cut the bowel cold, and then the ends of the bowel are kept below by a couple of hemoclips for later anastomosis. I don't use intracorporeal. We have sure foam, but I still don't use it. I prefer to do the bowel suturing at the end when we take out the specimen to the phalansteal incision, right, in the males. So then the 10 centimeters from the distal most part of the neobladder, we first perform the vesicourethral anastomosis. As you would do a Rocco stitch in the prostate, we take a Rocco stitch kind of a suture, seromuscular bowel to the urethra, periurethral tissue. Now we form the neobladder neck, small opening. You can see the long stump of the urethra here, so which is useful in continence. I use a quill suture for the anastomosis of both in a prostatectomy and in the robotic neobladder. It's a good barb suture with very fine barbs, unlike a V-lock. So that is my personal preference for all my robotic surgery, be it prostates or partial nephrectomies or neobladders or conduits. So continuous sutures, double-armed 3O quill, and you can use the bipolar as well from the left-hand side to suture the left-hand wall. The suturing begins at 5 o'clock, and this is the posterior layer is done. So about 4 throws on the posterior wall and 4 throws on the anterior. So around 8, whether it's a prostate or it's a neobladder. With the neobladder, of course, you need a perfect watertight anastomosis. And then you put the Foley in, which goes into the proximal segment of the neobladder. As all the way in, the Foley is put in, and then the anastomosis is done. Then we put in the ureters into the neobladder. So we make sure the spatulation is wide. I use ICG. I have not shown it in this video, but we use ICG to delineate the vascularity of the ureters, excise the terminal end, and put DJ stents as shown by Dr. Gagan. I use DJ stents in the neobladder. So that was the left ureter going in, and that's the right ureter going in again. So again, about 4 sutures on each wall, 4 on the posterior wall. The distal segment is excised and goes on for histologic examination. And the DJs are, of course, easy to put in. We put them in for about 3 to 4 weeks, and you need a flexible cystoscopy in the outdoors to remove them. So once the ureters are done, a segment of about 7 to 8 centimeters of the proximal end of the neobladder is left unopened, which forms the chimney. And then the whole neobladder is opened up. So once the neobladder is opened all the way, then we take the suturing of the posterior plate. Now the posterior plate will be unequal because one limb is longer than the other. So it will form a J with the tip of the J on the left side, or a hockey stick incision kind of thing, the posterior plate. And the suture is monocryl. I've used Quill, I've used Stratafix as well. I've gone back to using monocryl as I do for my open neobladders. So this is tedious suturing, but it needs to be properly done because you don't want any leakages. Again, this time it's a continuous suturing, all layers, and taking stay sutures between segments really helps to avoid the bowel from floating around and losing orientation. So then we take 10 centimeters on the left hand side and bring that segment on, as we showed in the diagrams of the Karolinska technique, onto the chimney end. So it will form now. So mattress suture is taken. So this will isolate the two limbs of the anterior wall. One is the lower limb and the one is the upper limb. And then both the limbs are sutured. Again, the suture is monocryl. So this ensures the double cross-folding of the mesentery. So that is the vital element which goes into a successful neobladder, in the sense that it forms a complete sphere with low pressures using the Laplace's law as outlined by Studer. And that's the distal limb of the neobladder being completed, and this is the proximal limb of the anterior wall. So we will put a suprapubic cystostomy at the end. You can do away with it. I don't put an SPC in the women, females. In the males, I still put a 14 French Foley as a suprapubic. And for the urethral catheter, I use an 18 French Foley. So at the end of the neobladder, we do a leak test by filling it up to 100 cc and take the specimen out. When we take the specimen out, we will then do the bowel anastomosis by stapling through the small 4 centimeter incision which we use for taking out the specimen. Otherwise, we have also used intracorporeal bowel stapling through a left-hand side port. And in women, we use the transvaginal staplings where the bowels are stapled. That's a separate video, but we don't have the time. Through the vagina, and that really saves an additional port. So in women, the specimen is removed through the vagina and the stapling is also done through the vagina. In men, you use another port to do the stapling, or you can use an open incision, small bowel stapling. So the catheter is usually typically kept for 2 weeks, and the Foley comes out on the 10th. The suprapubic comes out on the 10th or 12th day, and the stents come out in a month's time. Thank you so much for the opportunity, and any questions that you might have on the technicalities. Any comments?
Thank you for an excellent and beautiful video presentations. I think
Sorry about
videos have said it all, but otherwise, I mean, it's very excellent quality videos, and we have really gone through all the particular surgical details. Considering a bit of time constraint, I think, sir, we'll go ahead with the next presentation. I hope that is okay, Surya Prakash, sir.
Yeah, we'll take all the questions in the end. There are some questions in the chat box from the audience. After Dr. we'll take the questions.
So, our next talk is by Dr. Amar Singh, sir. Sir belong to USA presently and has been very extensive and vast experience in terms of uro-oncological surgeries, and one of the biggest advocates of continent pouches. I would like to request Amar Singh, sir, to take over the screen. Over to you, sir. Sir, you may have to unmute first, sir.
you hear me?
Yes, sir.
Thank you again, Dr. Kesamurthy, Dr. Mehta, for the opportunity to talk to you guys. So a little bit of historical perspective. I started doing neobladders early in career. However, due to incontinence issues and cathing issues, I have pretty much exclusively gone 80-20 to continent cutaneous diversion for a lot of my patients. So it's an old operation. It's been around since 1908. The concept behind it is using the ileocecal mechanism for continence, and hopefully during the talk I can show you how that's done technically, and over a 20-year career have had good outcomes. The only downside is stone formation, which if you live long enough, some of these patients will come back 15, 20 years later with a stone if they're not compliant with flushing. So who are the ideal candidate if they want continence without any external appliance? Urethra may be unavailable or high risk disease, or lower trigonal disease, or possible need for future radiation, or patients who have had prior radiation or other pelvic issues. Favorable factors, and some of the things to definitely keep in mind is that it's a relatively contraindicated if there are renal insufficiencies, cannot catheterize. So all these patients, we make sure they have good grip strength. They don't have any of the neurological conditions. They have good hand functions. That makes it a good operation. So procedure, after cystectomy and nodes are done, those are standard. We focus on harvesting the pouch, which is a segment of the colon. Then you divide the colonic segment, followed by folding of the pouch, urethral anastomosis, and then catheterizable channel creation and closure. And I'll try to go through these over the next few minutes. So pouch harvest involves terminal ileum harvesting and proximally ascending colon, and the length of it is terminal ileum is usually this is determined is a judgment based on how obese the patient is. If we have somebody who's morbidly obese, you want to harvest longer segment of this because you can always trim this, but if you're too short, that can make your life a little bit more miserable at the end. Ascending colon, you want to take it as high as you can so you don't compromise the vascularity of the enteric segment for future anastomosis. But most people, you can get this up to the hepatic flexure level without any difficulty. So this is a harvested colon. This is a case I just did about 2-3 weeks ago. You can see that's the terminal ileum, cecum here, and that's the ascending colon. And once that's harvested, then what we do is we distal anastomotic line it, excise, mainly in the US because we use a lot of staples. So you want to get rid of the staple line so it's not there for future stone formation. Second step is you detubularize the colon, dividing along the tinea with electrocautery or sharply. Then colonic segment is laid out, any fecal content can be cleaned, and then that's used to build the reservoir. So here again, you can see we're excising the colonic segment. Here it's opening up across the anti-mesenteric side, opening up the plate. And this is again now the divided colonic segment and the entire colon mucosa. Of note, we usually will do the appendectomy at the same time if they haven't had prior appendectomy done. And once we do this, again, schematically, it's that detubularizes the entire ascending colon portion, including including all the way up to the cecum. Then distal colon is folded into a transverse, forming a U-shaped posterior plate. And then posterior mucosa is oversewn, essentially a running suture. You could do 1 layer, 2 layer, depending on your preference. In here, we use a 3-0 V-lock running, makes it quick. You don't have to worry about tying, and you can run several series all along the posterior plate. So here again, you can see that Here are the two edges. This is the top of the U. That's the cecum here. And that's the terminal ileum suture that's going to be eventually developed into a catheterizable segment. And you put that together as a posterior plate. So now you have a nice wide open posterior colonic plate. At this point, we try to make sure, so the way I teach residents is I say visualize where the bottom of that U will be. The top of that U plate is your cecum and terminal ileum. That's going to be the one that you're going to catheterize. The bottom of the U is where your posterior plate is. And that's where you want to do the ureteric anastomosis. So ureteric anastomosis, usually in the most dependent portion, you can find a portion of the colon that doesn't have much vascularity to it, meaning doesn't have much mesenteric broad attachments. And you can bluntly pop that through with a right angle clamp to deliver the ureter, spatulate the ureter, and then do the anastomosis like you would do in any kind of urinary diversion. Typically, I use Foro PDS for those, but I'm sure you can use Quill, VLOC, anything that you prefer. So in that scenario, you can keep moving on, and once you get both ureters done, so here, let me see if, so with the right angle, we just pull that ureter up. There is the ureter. On the rightmost screen, you can see, hang on, there it's spatulated. And in most adults, I don't like doing any kind of anti-refluxing anastomosis. So these are just standard mucosal to mucosal full thickness anastomosis. Once this is done, I will pass a 5 French catheter through this, and the top end of that catheter comes through the cecal top. So this way, the pouch is relatively dry in the postoperative period for at least a few days, allowing the suture line to take place. And again, here you can see it in this picture. That's the ureteral mucosal anastomosis to the bowel. Once both of the anastomosis is done, then the next step is to close the pouch. So you can see here, after the anastomosis, stents are advanced, and then stents are brought through the top portion of the pouch. And then we also put in a Malacot there. That's kind of like our safety valve over the next several weeks that allows for the flushing as well as the pouch to heal. So here again in this video, you can see the stents are going in, and then they're externalized here outside. And then where the stents are externalized on the external portion of the pouch, we make sure we take some chromics to put imbricating suture line so it doesn't leak or anything like that when you flush it. Here you can again see those are the two stents that have been imbricated with the chromic suture. Again, here it's important to use chromic because these stents will come out in post-op day 4 or 5. And if you use some longer lasting suture, sometimes they can be a little bit more difficult to remove. Similarly, at this point, prior to completion of the entire pouch closure, we put the Malacot in. This will become kind of similar to a SPC catheter. So Malacot goes in and similar to G-tube concept, or just imbricate it all around. So when you flush it, you don't have much leakage. So at this point, a little bit of the pouch is left to close. Let me show you again in this video. It's just Malacot is secured, the stents are secured. Now the attention is done to create the catheterizable channel. Once the pouch is closed, the next step is we want to make sure we tailor the terminal ileum so we have a good snug catheterizable channel. Some of the pitfalls here, if you make this too floppy, it makes it more difficult for patients to catheterize because the catheter can get stuck in the redundancy of the TI or terminal ileum. So what I do is you put a 16 French Foley catheter. I always tailor it over a 16 French catheter. That's the anti-mesenteric side. You put some Babcocks on there, and here you taper it, and I'll show that to you in a video. So again, those are some Babcocks on excess. That's a 16 French catheter. and you can staple it, or when I do these in India, we don't have staples, so we will just excise it and run a suture line. So that's created, especially if you want to be more cost conscious, you can excise it and suture. It takes you extra 10 minutes, not much longer. And then you can see here, as we do that, now our catheterizable limb is nicely created, and that's secured. This is at the ileocecal junction on the outside. If there's some creeping mesenteric fat, you clean that up. And then I usually will take 2 or 3 of PDS to just reinforce that, almost wrap some of the redundant cecum over this area. So it creates almost kind of imbrication. And I do feel that that helps with further reinforcement of ileocecal valve. So again, you take a bite here on the seromuscular, and then that's the ileal limb, and then you can see how that cinches it in that video all around that. And you can do about 3-4 of these stitches that reinforces that segment fully. And once that's done, the entire pouch is completed. We close the pouch fully, the anterior aspect of the pouch that's closed. I usually like to use the canal stitch because that imbricates that entire mucosa inside, and now the pouch is fully closed. The catheterizable channel is tailored, the stents are externalized, and so is the malacot. So before we do anything further, we flush the pouch, make sure that the catheter, the 16 French catheter, can be catheterized easily without getting caught in anything, just to make sure you don't run into any future trouble. Once you flush it, make sure it's watertight, catheterizable is done. Now we are ready to essentially close and mature the stoma. So this just shows you the anterior closure of the pouch. And there you can see the entire thing is done. And then next step is to mature it and externalize it. So first thing we do is we externalize the 2 stents and the malacot. I usually like to do that on the right side of the abdomen because it just sits better since it's right colon. So again, these are externalized, and then we go ahead and mature the stoma. So around the umbilicus, I will put a coker on the umbilicus and evert it, and then just develop a flap there, and you can excise that if you need to. Let's see here. And there you can see on the third screen, we're delivering the catheterizable limb. And at this point, it's just a matter of just maturing the suture line. And I will use monocryl for this. And once that's secured, that's just like maturing any kind of ostomy or a stoma. And then this is just externalization of the malacot tube and the stents. They're all done, so it's in a dependent portion. Now, prior to closure, and you can see that's towards the pelvis here. That's the umbilicus area where we matured it. And then this is your externalization of tube. Once that's done, then posteriorly, we tack the pouch to the posterior abdominal wall at wherever it wants to sit, using usually some 2 or 3 of Vicryl at 3 to 4 points. So it stabilizes the limb and it stabilizes the pouch. And that just helps us make sure that it takes it off tension and is secured, and then ultimately do a cath check and then close them. And this is what they look like down the road. So this is a patient of mine from several years ago. He was a pilot for Delta Airline, and his biggest thing was he couldn't fly and he didn't want to carry a catheter or anything like that. And you can see it's pretty discreetly hidden. And most patients are able to catheterize. And the only downside, as I say, every operation has a downside. The biggest downside of this operation over a 20-year career, I've come to find out, is number one, the chances of colon leak is always there because we use colon, not small bowel. So that's something that's you have to be cognizant of. The second part is because colon makes mucus, you have to have patients who are willing to flush it at least once a week long term. Otherwise, they come back with stones several years later, and then you have to go deal with the stones. So overall, I think it's a very reasonable operation for the right patient that has good hand function, and they're willing to catheterize. Typical folks will catheterize on average about every 6 hours, and they can usually get overnight after about 6 months or so. So thank you again, and if you guys have any questions, I'll take it at this time.
Thank you, sir. Thank you for very excellent and detailed presentation on this topic. And I believe, considering the pros and cons and the relevant details that you have already explained, this really is a reasonable aesthetical option to those who patients really need continent diversion and yet cannot undergo neobladder. Surya Prakash, sir, shall we take any questions?
Yes. That was a great presentation, Dr. Amar Singh. Thank you so much. We have Dr. Uttam Mete, sir, is the Secretary USI. Sir wants to ask some question. Yes, Dr. Uttam, sir.
Yeah, thank you, Dr. Surya. Dr. Amar Singh had just presented this video. So
Your
there are
voice is
three
not clear.
parts of this continent weakness. So
I'm
actually,
sorry,
it may
can you
not be clear.
repeat
My
that again?
connection is very unstable.
The audio got
so
cut off.
I mean, there are three components of CCD or Indiana pouch. One is continent mechanism, second is anti-reflux mechanism, and third is the pouch. Now, what I can see from your video, I think the continent mechanism you had performed as the last procedure out of these three sequence. What is the sequence of making this pouch? Like you make the continence mechanism first, or you do anastomosis first?
So the sequence is
Not
the
audible?
first step is, so the sequence is that the first step is you want to make sure your pouch is of adequate capacity because volume helps you with continence. So usually the continence mechanism is the ileocecal segment. So I will usually do that towards the end. Make sure that the pouch is good capacity. Second step is you anastomose the ureter in the most dependent portion. And the third part is creating the catheterizable channel.
Okay. Anyway, so I do a lot of this Indiana pouch, and for me, the continence mechanism is the first because that is what we are doing for, and second is anti-reflux, and of course the pouch is there. So, anyways, that is the different way.
Yeah, we usually, I've never done anti-reflux, and I have not seen much of a issue in terms of hydronephrosis or loss of renal function long term. But 99% of the times I'm doing these in guys for bladder cancer, and the refluxing has not caused me much headache in this. It's actually bigger issue, I think, in ileal conduits in terms of hydro long term.
Because we are using colon, though we are detubularizing it, but still we cannot prove it. There cannot be a level 1 evidence. But I usually transtenial implantation with a tunnel so that it is anti-reflux.
Yes, sir.
Anyway.
Thank you, sir. I think with this, we would like to conclude our discussions and presentations. I would like to request Dr. Surya Prakash, sir, to give concluding remarks. Sir.
Amish, there are a few questions in the chat box. I think they're addressed to Dr. Ileal conduit topic, Dr. Gagan. Is Dr. Gagan there? Or then you can take the question.
He seems to have left, considering other commitments, sir.
There are a few questions about, again, stents. Dr. Shanti Swarup has asked, when do you remove the stents and what stent size? Would you like to answer, Dr. Ramesh? Or any one of the speakers can answer.
So usually 2 to 3 weeks is the time we remove the stents if they are external or even the internal stents.
Okay. So how do you prevent mucus plugs blocking the stoma in the conduit?
Sorry, what was that?
Mucus plugs blocking the stoma.
It rarely happens. I haven't come across a single instance. So that would never be an issue, I guess.
Correct.
I've never seen that. I mean,
Yeah,
most of the times water can run through the mucus anytime. And
yeah.
stents for Indiana pouches usually we use a 5 French open-ended polyp catheter, and that will take out on post-op day 4 or so, thereabouts.
Okay, thank you. Dr. Amar Singh, I have a question to you regarding the continence mechanism. Do you think the imbrication plays a major role or the ileocecal valve?
So these are, it's in surgery, there are so many things we are taught, and we do it because somebody did it and someone showed us. The only way, if it's not broken, don't muck with it. And for me, that's how I learned it. And I have done it for all these years and I've had good outcomes. So I try not to change it. But to prove it, what came first, the chicken or the egg, I'm not sure how we can really study it or prove it. But I think the ileocecal works, and also I do wrap it quite a bit, and I have not had much of a challenge with it, or I have not seen any adverse. But that's a very good question, and I'm sure down the road, if somebody randomize it to group and see if any one of them does better, then we can eliminate it. But so much of it is dogma and something we were taught. So I'm grateful to my mentors for that.
Thank you, Dr. Amar Singh. Yeah, Amish.
So yeah, I did have a question. I'm sure I could get a quick answer. Sir, what are the steps that we can take to avoid metabolic complications in continent diversion, whether it's neobladder or the Indiana pouch? Bakshi sir?
So yes, so about the neobladders, I think Dr. Amar Singh will answer about the Indiana pouch. But for neobladders, the thing is to start soda bicarbonate immediately in the post-operative period to keep that is the first thing. Second thing is to keep the pouch empty at all times, to see to it that the pouch doesn't get distended with urine and get absorbed. So the initial couple of months are vital as far as the metabolic complications goes. You should be able to recognize hypermetabolic acidosis when it happens. But supplementing with soda bicarb, keeping the fluids right, avoiding PPIs has been recommended by Studer. Proton pump mechanism gets disturbed. So all 2 or 3 factors which would prevent metabolic complications. Keep the neobladder empty at all times. Don't let it distend to prevent reabsorption of urine. Frequent bladder washes about 3 to 4 times a day through the suprapubic and the urethral catheter, that helps.
I think the biggest thing for Indiana pouch in early post-op period is that it's maximally drained with the catheters. So that helps you kind of get through the perioperative period. Usually at about 4 weeks is when we remove everything and they can go back to catheterizing. And similar to what Dr. Buxy said, I think keeping the pouch catheterizing and compliance with cathing is the best thing you can do to minimize any metabolic issues. The longer the urine sits in there, more the stasis, more metabolic complications you'll have. I'm curious to see what Dr. Uttam has to say about if he has any insight.
Right, sir. Thank you. Thank you so very much, sir.
Now, there's a question from Dr. Manoj Kumar. Dr. Uttam sir, would you like to respond to Dr. Amar Singh's?
This is regarding that mucus, isn't it?
Yeah, well, do you have any other pearls of wisdom on how to minimize metabolic complications in Indiana, since you said you've done a lot of them as well?
I don't think any other way. So basically, we have to, have minimum segment of the gut. So I don't know what exactly you divide the colon. I don't take more than 15 centimeter of the ascending colon, because some people they take the transverse colon, the medial 1/3 of the transverse colon also to increase the size of the pouch. But I don't go beyond 15 centimeter from the ileocecal valve.
Usually we'll go
So
up
that
to
is
the
one.
hepatic flexure or a little bit lower than hepatic flexure, because once you go beyond that, your your vascular supply to the enteric segment gets compromised a little bit more. So usually I think a little bit below hepatic flexure is sufficient.
Because I have seen over a period of times, 5 years or 6 years, these pouches they become very weak because these people they don't do the AC properly, because especially at night and it becomes very voluminous. So that's why there's no point taking a huge segment of the gut. And one of the way of reducing the complications of metabolic complications is the reducing the surface area, isn't it? But there will be some changes over a period of time. There will be some metaplasia, isn't it? So as a surgeon, technique-wise, rather than only reducing the surface area, you don't have any other way to reduce the metabolic complications, isn't it?
Okay, sir. Thank you. Dr. Ramesh, there's a question from Dr. Manoj Kumar. In a patient with solitary functioning kidney, when we do a diversion, would you prefer a cutaneous ureterostomy or a conduit with single ureter? Any of the speakers can take this question.
So it will depend on the, sorry.
No,
Yeah.
I was gonna say cutaneous urostomy invariably fail in adults.
Okay.
I mean, if they live long enough, now if somebody's gonna die next 2 years, then you're fine with the cutaneous urostomy. So I think a conduit is the answer in most of these cases, regardless of their solitary kidney or not. At least that's been my experience. I've done probably early in my career, I did a few cutaneous urostomy when the ureter was dilated like a big hose. And
Oh.
every one of them, they stenosed after 2, 3, 4 years, and we had to go back in.
Okay. Okay. Fine. Thank you.
Does that make really any big difference, sir, that avoiding any bowel resection in such cases, other than maintaining the stoma, which nearly is going to be the same as condiostoma? I mean, is it really going to make any big difference? Say, sir already say that it's on the left side is wise to perform a cutaneous ureterostomy to avoid any conduit. But on the right side, because the conduit would remain handy and accessible, it would be okay. However, end of the day, for patient, it is stoma maintenance. It is for us to see that we are saving any intraoperative time, any hassle and bowel related complication. But in real life, to patient, does it really translate into any significant difference or benefit? Bakshi sir,
So if the patient is sick and morbid, you would do a ureterostomy. That's very true. A limited life expectancy, bad disease, single kidney, bad comorbidities, you would do a ureterostomy, as Dr. Amar Singh rightly said, a couple of years to live. Fair enough. You can do a ureterostomy. You can do a bilateral double-barrel ureterostomy like you would do in a single stoma, to get the left ureter down to the right. So it would avoid the bowel complications you mentioned. But given the preference, if the patient is doing well under anesthesia, is going to live a little longer, even if the patient has a bad disease, the conduit is always any day preferable to a ureterostomy. That is certain.
Right, sir. That is well
Because
explained.
there are some patients where we'll get patients with compromised renal function. So in that cases, most probably would not like to put any bowel segment. So there, but it is really technically maybe easier, but it's very difficult. Say for example, somebody's creatinine is around 2, and you don't want to put any bowel, and it is because of the benign disease like a GUTV. Commonly, what we find, one-sided kidney is knocked off, only one kidney is there, and you don't want to put any bowel. So maybe that is the situation where you can consider, but I fully agree with Dr. Amar Singh that it really doesn't work. We have to put a ball segments for a functioning staff.
Right.
Okay. Okay. Yes, Amish, if I think there are no more questions, would you like to say any concluding remarks before I conclude? Amish, any comments from your side?
Sir, no, nothing, sir. This is it, sir.
Okay, then we'll close the session. I thank all the speakers, Dr. Ganesh Gopalakrishnan sir, Dr. Himang Bakshi, Dr. Gagan Gautam, and Dr. Amar Singh sir, international faculty. All your videos are very excellent, and I think it was very useful session. It's such a difficult topic, not routinely done, but the videos are excellent quality, especially Dr. Bakshi's robotic video and Dr. Amar Singh's video. Dr. Gagan.
Yes, sorry to interrupt you. Can I just pass 2 comments?
Yes, please.
Yeah. So, see, you have to decide about the cost of diversions. Any patient who is on a stoma bag, the cost of maintenance is around 2 to 3,000 rupees per month. On the other hand, if you go for CCD, the cost of one catheter is less than 300 rupees. So 300 versus 3,000. That's why I think in an Indian context, most of us should learn how to perform CCD. It is not a very difficult job, surgical skill, You should learn it so that we can help. And most of my patients who are on extrophy, adult extrophy epispadias patients, they are on CCD. So their cost of living is very, very less. And I think that is the reason why an Indian surgeon should learn CCD more than ureterosigmoidostomy. I think is outdated now. It should not be done. And a patient with advanced malignancy who is going to live a shorter period of time, I do agree with what Thomas saying. So islet loop is fine. Otherwise, CCD is a better option for Indian patients, because even if you go for a neobladder, Studer had come to our place, and in his series he says 40% of the Studer neobladder after 5 years may not work. They might require CIC. Now, if you are planning for a CIC, then why not a CCD? Why to pass a catheter through the urethra, which is painful, which will be painful, rather than passing a catheter through the abdominal stoma, which is less painful. So that's why, in my opinion, if you are planning for a CCD for a benign disease, for a continent diversion, it will be CCD. And that's all. Thank you very much.
Thank you, sir. Thanks for your comments. So with those, I think we'll conclude the session. I thank all the audience who have participated in this. This session is recorded, and if somebody wants to watch it later on, we can watch it through the e-learning platform. And thank you very much for participating in this session. Thanks, Amish, especially. Thank you very much for selecting such a topic, very useful topic, and convening this session. I thank Dr. Uttam sir, Dr. Keshav Murthy sir for joining the session.
Thank you
very
for
much.
the opportunity.
Thank you, sir. Thank you
Thanks.
very much.
Thanks.
Bye.
Thank you.
Bye-bye.
Thank
Thank
you.
you, everyone.
Thank you.
Thank you.